The program is about to begin. Wonderful. Awesome. Well, hey there, everyone. My name is Nick St. Fleur. I'm a science reporter here at STAT. I'm also our Associate Editorial Director of Events, and I host our podcast, Color Code. I'll be the MC for today. So we have quite the packed agenda today. We have Javier Becerra will be coming later today. We have just so many big names coming. I want to start us off first with some opening remarks from our executive editor, Rick Burke. Rick Burke, go right ahead.
Thank you, Nick, and I hope people will tune in this spring for the second season of Color Code, Nick's podcast, which is the only podcast I know of that focuses on the intersection of race and science, and it's really absorbing and important. I just wanted to very quickly thank you all for coming and also tell you how important DC is to STAT. We now have 8 full-time staff members in Washington, and I hope if you haven't already that you'll sign up for our free newsletters, our twice-a-week DC Diagnosis, our weekly Business of Healthcare newsletter. You all know Ed Silverman and his Pharma-Lot, his Pharma-Little columns. He's not in DC, but he's an honorary DC person. And I also just want to tell you, STAT is, we're really excited about events like this. STAT is on the move. We're growing and expanding in terms of all kinds of new coverage areas, and we're opening our first international bureau in Europe next month. So stay tuned, and thank you for coming again and for your loyalty to STAT, and have fun tonight.
Wonderful. Thank you so much, Rick. Before we begin, I just want to give some housekeeping. I hope that everyone can silence their phones. So these will be some really interactive conversations you'll hear today, and you'll see me walking around with my microphone. If you have a question, just feel free to flag me down, raise your hand, and we'll make sure that it gets asked to our panelists here. Before we start, I do want to give a quick shout out to some new members we have on our DC team, like John Wilkerson, our Washington correspondent. John, there you are, hey. Lizzie Lawrence, our medical devices reporter. Lizzie, there you are. And then we have Catherine McPhail, who is on the events team with me, right over there. Okay, so today you'll be hearing a lot about healthcare policy here in DC. But to start us off, I want to have some opening remarks. So will be from our sponsor, Tamar Thompson. So I want to say thanks again to Alexion, AstraZeneca, Rare Disease, and to all of you for joining us here this evening. So to kick things off, our sponsor, Alexion, AstraZeneca, Rare Disease, please welcome Tamar Thompson, Vice President, Head of Corporate Affairs at Alexion, AstraZeneca, Rare Disease.
Can everybody hear me okay? It's good? All right. Good evening, everyone. And I feel kind of ridiculous announcing myself again, Nick. So I'm Tamar Thompson. I lead corporate affairs on the Alexion AstraZeneca Rare Disease side, and I am so thrilled to be here with all of you this evening. Tonight's conversations about the politics of healthcare is a really important one. And for each of us in this room, we have the potential and the power to impact the future of health. At Alexion, we are firm believers that public-private partnerships are key in ensuring that there is innovation, opportunity, access, and equity for all patients, especially and including the rare disease community. We are coming off the heels of Rare Disease Day, which is a global event that is held on the last day of February each year. And for us at Alexion, every day is Rare Disease Day. But this day reaffirms our mission of supporting the rare disease community worldwide. And a key factor in our ability to carry out that mission is to advocate for strong public policies and regulatory frameworks that help, not hinder, patient progress. There are 4 million people worldwide that are affected by rare disease. And today there are more than 7,000 known rare diseases, but only 5% of those have an FDA-approved treatment. On average, it takes nearly 5 years for a person to be diagnosed with a rare disease. And the odyssey to that diagnosis involves multiple doctors, countless specialists, and unfortunately, several misdiagnoses along the way. But this journey can be even further compounded for racial and ethnic minorities who are in otherwise marginalized groups. The rare disease patient community inherently faces inequity. And there's already an uphill battle for those to get a clear diagnosis. But when you think about that, when they get that diagnosis, more than 90% of those rare diagnoses do not have an FDA-approved treatment. And for those that are already in marginalized populations, for example, Black and brown, low-income people, they're facing deep issues of inequity, and adding rare disease diagnosis puts them in an even greater position of disadvantage. And so for these reasons, we must work with a sense of urgency to eliminate the barriers between patients and the care that they deserve, and to ensure access and equity for all patients, regardless of their race, background, socioeconomic status, or GeoZip. And so here in the US, we've all seen what happens when we come together for good policy. That sparks innovation and helps to create opportunity and access for patients. And this year, ironically maybe, we are commemorating the 40th year anniversary of the Orphan Drug Act. Thanks to ODA, companies like Alexion have been able to make tremendous progress in working side by side with the patient community and valued stakeholders in developing critical treatment options for rare disease patients. ODA considers the unique challenges involved with the rare disease drug development pathway and clears pathways for companies like ours to help more rare disease patients live fuller and healthier lives. Other countries have even used ODA for their own rare regulatory disease pathways. And before ODA, there were 40 approved drugs for rare disease in the US. Now, there are more than 550 unique medicines. Yet with all that progress, there are other pieces of legislation that threaten to undermine what the ODA has come to stand for. The Inflation Reduction Act, for example, includes some provisions that undercut the very premise of the Orphan Drug Act. You see, unlike other healthcare conditions, rare disease is just that. It's rare. And at Alexion, that means that we're setting out to develop first of its kind medicines. And to do this, we often start by building upon our existing FDA-approved treatments, ones that have already been successful in treating patients. And quite often, that is what leads to the innovation that can address not one rare disease, but multiple rare disease and multiple indications. But the IRA dampens our ability to continue with this work because it disincentivizes development of orphan drug treatments for more than one indication. And simply put, that's just fewer treatments and fewer patients reached. I believe that everyone here tonight agrees that the healthcare system must evolve and that it must innovate to benefit patients. But we also must push back on harmful policies and attitudes that threaten to take us backwards. And so it's up to all of us to show patients that they are not alone in this fight and that they depend on us and we will come through for them. So let's do that. Let's show the patients that we will come through and get this right for them. I thank you for the time, and I hope you enjoyed tonight's conversation.
Tamar. So for our first session, how will the Inflation Reduction Act affect drug pricing and Medicare? Please welcome to the stage Dr. Meena Seshamani, Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. And to moderate, Rachel Kors, Washington correspondent here at STAT.
Thank you so much for joining us, Dr. Seshamani. We're so excited to have you. So you are a Johns Hopkins trained surgeon, and you also have a PhD from Oxford, and you led Obamacare implementation, you were a healthcare executive, you've done a lot of hard things. So where does kind of the whole endeavor that you've embarked on of implementing drug pricing reform from scratch, essentially, rank on that list of hard things?
Well, is this on?
Yeah, we're good.
Does parenting children also count on the list of hard things?
Fair.
There we go. I mean, I will say that it is an incredible opportunity to be able to work on drug pricing. I mean, I've taken care of patients by PhDs in economics, right? It's the ability to bring those together where I have taken care of people and seen where the system works, where it doesn't. You know, for example, one of the things before I took this role, I was leading care transformation at a major health system and, you know, leading our diabetes management efforts, our diabetes care pathways. And the patients that we had who couldn't afford their medications and had diabetes that couldn't be controlled, and they'd say, well, what do you want me to do? I can't pay for this, right? And now we were able to make insulin capped at $35 in Part D, and starting in July for the insulin pump, it will be at $35. I mean, that's really tangible impacts for people where from my one-on-one experiences with someone to be able to take that and bring it to that macro level, you know, to really be able to affect change across millions of people and really drive change through the system. Again, it's really an amazing opportunity to work on this.
Right, so you brought up the insulin caps. Like, how has implementation of that been going so far? Are people using the special enrollment period that's opened up? Can you just tell me, have you been getting calls from people who are confused? Like, how's it been going so far?
Yeah, absolutely. It's been going very smoothly. And I will say, you know, as soon as the law passed, I was on the phone talking with our, you know, with health plans saying, okay, it's a partnership, right, in terms of, you know, being able to implement this provision with the Part D plans and really, you know, stepping up and implementing this on a tight time frame and successfully implementing it. You know, the calls to the call center are minimal, and really people are able to get that benefit. In fact, the calls that we get to the call center a lot of times are thanking us, saying, oh my gosh, I was able to get my insulin for a lot less. And, you know, where there are some plans that are still, you know, operationalizing, putting it into place, those very, very few, it's the vast minority, they have in place reimbursement to people, you know, that goes until, it has to be done within, you know, 30 days of purchase, and that all has been going very smoothly as well.
Great. So, I mean, obviously that is in place already, but there's a lot of the Inflation Reduction Act that is not in place yet. You know, work is underway for implementation. I know you've been having a lot of conversations with stakeholders, including drug makers. So, can you tell me kind of what the point of discussion you hear the most is when you're having conversations with pharma companies in roundtables and phone calls? Kind of what's your biggest point of feedback been?
I mean, I think honestly, the biggest point of feedback has been the fact that we are engaging and getting feedback, where people have said, oh, this is really great that you are reaching out and you want to talk. I said, yes, because again, having worked as a healthcare provider on the ground, everybody in the healthcare ecosystem has a perspective, has data, has expertise, experience, and it's so important for us to leverage that when we're thinking about complex issues, and to be able to engage with pharmaceutical companies, with patients, with plans, with providers, with academics working in drug pricing, so that we can really hear from all perspectives and hear, okay, what are the things that you think that we should be taking into consideration? What is data that you have that you can bring to bear? And it's been really amazing to be able to, in some ways, bring all of these voices together, right, in a way that maybe hasn't before in the area of drug pricing.
So can you give us any hints as to if there's been any, policy brought up during that discussion, any points where, you're already kind of seeing things are moving fast. And I think, we have a, list of 10 drugs that are going to be negotiated, released by September 1st. So I'm curious if you can offer us any hint into that, conversation, that discussion beyond the fact that it's a good thing that it's happening.
Yeah, I mean, I think one one theme that definitely, has come about, through the various conversations is the fact that people were saying, okay, well, how are you going to actually implement this, and how do I make sure that my voice is heard? So as you may have seen, I think it was January 11th, we put out a roadmap or a timeline for how we will stand up the Medicare drug price negotiation program. And that was very much, with this feedback, okay, when you have something that's this big, being able to actually lay it out. What are the different pieces that are involved in standing this up? And then where are the opportunities for people to engage, right? So you can harness that collective energy towards standing up this program. So that's one example of a theme that we definitely heard, where we have said we're going to be putting out draft guidance, getting comments, highlighting what are the areas, that we want to get comments on, how we want to get comments on what data to collect as part of the negotiation process. So that was a major theme.
So mentioning the drug list that's supposed to be coming out in about 6 months, obviously some of the parameters are laid out in statute. Everyone's very anxious to see it, but there is some discretion too as to what drugs go first. So I'm curious if you can give us any insight into kind of the secret sauce, the deliberations, kind of the process of kind of creating policy around who's going to be first and kind of how this process is going to work in its first iteration.
Yeah, and I mean, to take a step back in general, right, when we do policy making in Medicare, you have the statute, right, the law that you follow, and where the law has discretion, then that's where our regulations, guidance, et cetera, come into play. And so, as you mentioned, with the drug selection, there's quite a bit that is in statute that, we will be following. And as we talked about in that timeline I mentioned, we will be putting out, draft negotiation guidance that will kind of go into some of that area more. But just what the statute lays out is looking at the top 50 drugs in Part D in their spend. There are various exceptions that then are taken out, like orphan drugs, blood and plasma derived products, drugs that have less than $200 million in Medicare expenditure, drugs from a small biotech company. We have also put out the data collection that we'll need from manufacturers who want to be considered for that, right? So we take all of those out, and then you have, what are the top drugs after that.
Excellent. And we talked about negotiation a bit. I want to touch on kind of another big policy that your agency is implementing, which is the penalties for drug makers that hike prices faster than inflation. The law allowed CMS to start penalizing drug makers as soon as this year, or to delay until 2025, and my understanding that the choice has been to delay until 2025. And I was wondering if you could explain that decision and kind of why not start this year?
Yeah, so to be clear, we hit the timelines in terms of, right, when the inflation rebate starts. The inflation rebate started for October for Part D and January for Part B. The clock started, and the calculations will take all of that into account. The invoicing begins in 2025, and that is because there are operations that need to be stood up, both on the CMS side and on the manufacturer side. And I think this is one of the things also, as we have been engaging, being able to marry policy and operations so that things can actually work on the ground is very important. We have monthly technical calls with plans and with manufacturers, specifically to think about how you operationalize things so that we can make sure that things are working.
Absolutely. So when you talk about operationalizing this program, you're doing a lot of hiring. I think the estimates that were that you could hire up to almost 100 full-time employees, and I know that your agency kind of posted a listing for the director of this new group back in the fall, and it's now been reposted this spring. So I was wondering, can you tell us, are you still hiring for that position? Has there been difficulty? What's your pitch to people? Because it's a hard thing, putting up a very controversial policy like this.
Well, we are hiring. I will say we have incredible expertise within CMS. This is the team that stood up Part D, and we have a lot of longevity in CMS. So a lot of the people who stood up the Part D program are still working at the Center for Medicare. So we are harnessing that deep expertise, and we are also hiring economists, clinicians, managers, analysts, and that hiring is moving along. And, in terms of what's your, recruiting call, I'll come back to where I started. This is an incredible opportunity to improve access to care, make care affordable, really drive change in the system, that I think it's a great opportunity for people to work on.
Absolutely. And another program that it's not directly under your purview, it's in CMMI, but the Biden administration announced 3 kind of demonstration projects that they're thinking about on drug pricing. 2 of them are related to Medicare, which would be offering generic drugs for chronic conditions for $2, and also I think there's paying less for drugs that were approved through the accelerated approval pathway. So we didn't really get concrete timelines for either of those in the announcement, and the Medicaid demonstration, which is separate, wouldn't launch until 2026, which is beyond the end of the current administration. So I'm curious how confident you are about, these 2 Medicare models. Do you think they can really get off the ground before 2024, or is that something that could stretch, beyond that timeline?
Well, Rachel, you are right that does not sit in my center. But what I can say is this is a good example of how Medicare and the Innovation Center partner and work together. The Innovation Center is kind of the R&D arm for Medicare and Medicaid. So where there is an opportunity to be able to test new models and see what works and then scale and incorporate in Medicare, the executive order and the models that CMMI is thinking about is a great example of that. In fact, the $35 copay for insulin that we talked about that we rolled out January 1st, that was a CMMI model that Congress then took up and put it through the Medicare program. And so I think there are those opportunities for continuous learning and where the CMMI models can really complement and further the work that we do in the Medicare program writ large.
Again, we are taking questions, so if you have one, feel free to raise your hand and find Nick. He'll be walking around with the microphone.
We have a question right here, Rachel.
Okay,
Thanks
great.
for
We
the
can
plug.
take one. Yeah.
Hi, thanks for doing this. I wanted to get a little bit into the nitty-gritty here. So I was just wondering, there's several, as you point out, outstanding questions that need to be answered. I think one of which I'm wondering is whether you think CMS has authority under the law to require that a drug subject to negotiation is the preferred drug on a PBM formulary. And if you do, what do you think of that policy? How are you thinking about that with the PBMs and the Part D drug plans?
Thanks for your question. I will say that there are many things that we are exploring, right? Coming back to where you have, the statute and then figuring out, what you put into guidance. So I can't speak to, any specifics, but absolutely, we are in listening mode and we have been around these kinds of topics to hear, what people think among the various stakeholders as we evaluate and figure out, where we move.
Okay, and I also wanted to ask you about the budget, because there was an announcement about some kind of White House initiatives on drug pricing and how that relates to the Medicare program this morning. And one of the policies talked about making sure that patients are really seeing cost reductions on drugs that are negotiated by Medicare. So I was curious how you're thinking about that policy right now. If Congress doesn't take any further action, how is Medicare making sure that patients are actually going to see lower costs at the pharmacy counter for these drugs?
Yeah, I will say, and again, I say this as a physician who literally on my smartphone with one of my Medicare patients, we would get on GoodRx and try to find, a drug that I could prescribe for her that she could afford. It is very important that the people that we serve in the program see the impact, have that financial relief, have the ability to get those medications to stay healthy. That is front and center. Everything we do is for those people in the Medicare program. And so to that end, the $35 insulin cap, vaccines at no cost sharing. How many people have not gotten a shingles vaccine because it's cost up to $200? Or, when I do roundtables with seniors and they talk about giving money to their brother so their brother can pay for their insulin, right? It affects families and communities, not just that person. The $2,000 out-of-pocket cap will be huge. For anybody who takes quite a few medications, to have that security knowing that there's only so much that you are going to have to pay. So there is quite a bit in the Inflation Reduction Act it got bright all of a sudden. There's quite a bit in the Inflation Reduction Act to make sure that people see the benefit. You know, the last one in our proposed rule, we're starting to implement the expansion of the low income subsidy program to 150% of the poverty level. So again, really tangible benefits for people that is so critical.
Excellent. We have a question right over here, Rachel.
Yeah, hi. I was wondering, going back to some of the details of the products that will be selected for negotiation, when you mentioned the top expenditure, is that based on gross or net expenditure for the products? And I guess the other question I have is, when you've talked to stakeholders, what are the biggest concerns that you've heard from the different stakeholders over potentially mixed incentives that might be introduced by the law? And I think we heard about a few of those in the introduction.
Yeah, thanks for that question. So in the proposed C&D rule that we put out this fall, we made a clarification to our regulation to better match statute around gross expenditures. And so that is in proposal, comment period has closed, and we're evaluating that, so that is kind of in process. And in terms of in terms of what we hear from stakeholders, it really does run the full range, thinking about operational considerations for implementation, thinking about access, thinking about affordability, thinking about innovation. And I think all of these have come up in all of the conversations across all of the stakeholders.
Yeah, I'm going to ask a question that's a little bit more high level. So in 2021 and 2022, there was a lot of action on the Hill. There was a lot of uncertainty as to what legislative framework you'd even be looking at this year. But now I think with the divided Congress, I think there's a lot less potential for these transformative changes in the Medicare program. So I'm curious whether that dynamic opens up kind of an opportunity for CMS to pursue ambitious rulemaking now that there's some certainty on the legislative framework.
Well, I would say that we have been making a lot of change. We have our vision for the Medicare program, which I put out not this past January, but last January, really centered around how we can leverage the Medicare program to drive advancements in health equity, where everyone has a fair and just opportunity to attain their optimal health, regardless of culture, language, geography, sexual orientation, gender identity, race, ethnicity, the numerous factors that impact someone's health and ability to access and navigate the healthcare system, where we can expand access to coverage and care, where we can drive innovation so we have high quality whole person care, and how we can be good stewards of the program. And all of our rulemaking has really been advancing those goals. So for example, where we are expanding on value-based care, and we created a program that will give upfront investment dollars to smaller providers in rural and underserved areas so they can invest in the infrastructure needed for more whole person care, so they can partner with community-based organizations, so they can address health-related social needs. Rolling out 200 new GME slots a year, prioritizing rural and underserved areas. All the things we're doing on behavioral health. I mean, the list goes on, and we've written up quite a few of these, which we can, share. So I think we just continue to move forward, right? We have our North Star. We want to serve the people in the program, and that's what we will continue to do.
Excellent. So I think our time is coming to a close, but my last question for you is also a budget question that I think is going to come up on the Hill. The White House proposed potentially expanding the Medicare negotiation program already. It hasn't even been implemented, but they're talking about more drugs, about shortening the timeline for eligibility. Does that stress you out a little, since you're the one working on this day to day? Is that even possible to implement?
I mean, we are hitting our timelines. We have our framework out for how we are planning to, and doing so in collaboration with everyone in the healthcare ecosystem. It comes back, Rachel, to where we started on the insulin and the vaccines, where I'm very well aware of the collaboration that's needed across the entire healthcare system to make sure that we're all delivering for all the people that we collectively serve together.
Great. Thank you so much for joining us.
Thank you.
Wonderful, wonderful. That was a great discussion. Next, for a sponsored discussion, I'm thrilled to welcome back to the stage Tamar Thompson, the Vice President and Head of Corporate Affairs at Alexion AstraZeneca Rare Diseases, and Nick St. Fleur.
Wait until I get up here. I'm scared of these steps. I really am, Nick, these baby steps.
Perfect. Awesome. Yes, you're perfect.
Hey, Nick.
Great. Hey, Tamar, how are you doing?
I'm good. How are you?
Yeah, so I figured a great way for us to kind of begin this discussion is to talk a little bit more about yourself and what brought you to Alexion.
Okay.
Tell us your story.
My story, oh wow. It's a little bit different than probably most of the people in this room. I did not go to, GW. I didn't work on the Hill. I wasn't at CMS. I am an Air Force wife who found her way here because my husband went to the Pentagon and went to a little consultancy that some of you may know called Avalier Health. Worked there for a while, and then went to a boutique lobbying firm, and then found my way into Bristol Myers Squibb. And at Bristol Myers Squibb, I learned a lot about rare disease. And that took me on a journey, just kind of a passionate one, learning about these patients. And when I got a call from my good friend from Avalier Health, Tanisha Carino, saying, hey, I'm coming over to Alexion. Would you want to join me on this journey for rare disease patients? I said, yeah, and I've not looked back.
And how has the journey been so far?
It has been so rewarding. I am so grateful that I get the opportunity every day to get up and serve this community. These patients are just, I'm going to cry. These patients are just so wonderful. Their challenges are so significant. And each time we meet with the patients, they're so happy to have treatment options or just happy to be able to live their lives every day. And I'm just so grateful to be able to amplify their voices and message.
Yeah, no, I'd love to stay on this subject. I mean, tell me a bit more about, working with these patients. Is there any specific anecdotes or people who come to mind when you really think about everything that you're doing and all the work you're doing?
Sure. We just interviewed a patient for Rare Disease Day who has HPP and talked about prior to getting on treatment, how his journey was as a child growing up. And the family he's Southern from, Kentucky, and he was like, he's just a weakling. The family just kind of wrote it off that he was just, a sickly child, and he wasn't. He had HPP, and unfortunately, he was misdiagnosed up until his early, adult years. But now he has gone through the journey that I talked about earlier, 7 to 10 years of, trying to find the right treatments, and now has done that. And he's living a very normal life. He has 3 kids. He just had 2 twins. And that wouldn't have been possible without treatment. So I think about his story, and I think about, many of our patients when we're doing the work that we do every day.
And what does that mean to you to be able to help these patients, to treat them? What does that mean to you?
It is so rewarding, but my own personal journey, and I think you know this, Nick, we all work in the space of the healthcare continuum, but when you become a patient, it really hits home. So for me, last year, my husband was diagnosed with prostate cancer, and he is a declarated officer in the U.S. Air Force, and I'm very proud of that, but I was not going to let him be seen at I won't say the name of the hospital, but you all know what it is. So we went to Hopkins because the journey was very difficult. We didn't get things that I thought he needed to have. And I won't say that's because he's a black man. I will say it's because I just knew what I knew from having worked in the cancer space. I knew the genetic testing that was available for him that he should have had, finding out that his uncle and his father also had prostate cancer, so we should have had options for testing to make sure that he had the right treatment options. And so when you're thrown into the system in such a way, it's easy to navigate the system as a policy wonk and say, well, the patient's need. But when you are the patient, or when you're the patient navigator, it becomes a completely different experience. And so for our patients, I just think about my journey and what I've been on with my husband this last year. Most of the rare disease patients in our sphere have a caregiver 24/7 every day of the week because they are disabled. A lot of them are children, And so it really is important that we give this community the credence that it deserves to have equity, to have the ability to have fulfilling lives. And so it's just so important, and I'm just so grateful to have the opportunity to be the representative for that.
I'm so happy you brought up health equity. As you know, that's a subject close to my heart as well. Tell us a bit about your passion for health equity and what Alexion is doing.
Thank you for the opportunity. So, I just told you my own story, and that's just one piece of it. But I think that, growing up as a minority in the South, you see things, right? You see the difficulties that you go through, your family goes through, and it's not until, for me, it wasn't until I came to DC or quite frankly even got into life sciences that I learned that, oh, that's not okay. I just remember how my grandmother was treated. We're from Texas. You can hear my accent sometime, y'all will come out. So, but I just remember how my grandmother was treated in healthcare, and we just kind of accepted it. And looking back now, my team, thank you for being here, know that we just went through an experience in my family, and I called God and everybody. I called the Congress. I called 15 people to get the help that was needed for my family. But lots of people who are, underserved or minorities, Black and brown people, don't know that that's an option for them. They don't know that the system isn't serving them. And so, for me, that's a personal passion. But at Alexion, we are doing so much work, and I'm so proud of it. I think I'll give a shout out to Lisa Fang, who is working on a white paper right now to talk about the inequities in healthcare for rare disease patients. We've sponsored and worked with Every Life on the burden of rare disease and the challenges and the inequities that we have in the rare disease space.
And I believe you mentioned in your opening remarks how it is the 40th anniversary of the Orphan Drug Act.
It is.
Tell us a bit about why that is so important. Why do you commemorate it?
It's so important because I said prior to ODA, there were 40, not 4,000, 40 approved treatments for rare disease patients. And now there are 550 plus, and that doesn't sound like a lot when you're looking in other disease states, but for a community where there's 7,000 plus, diseases, and you have so few treatment options, ODA has created a pathway for us to make sure that there's opportunity for equity for those patients.
And we just heard a conversation on the IRA, and I wanted to give you the opportunity to kind of share with the audience here. What are your thoughts on, the IRA as it applies to rare diseases?
Sure. I think that overall, every piece of legislation has the intention to do good for the community. Sometimes, we don't always get it right for everyone, and that requires work to go back and to maneuver. Talking to CMS and talking to the Hill to get it right. But I think for us, the IRA fails, quite frankly, to address the needs for the rare disease community. Having a one indication is not a viable option. When you look at our products in our portfolio, we have multiple indications, multiple disease states, as I mentioned in the opening. And so this, to me, is a miss and a failure. And I don't think that was the intention of the Congress. I think it's an unintended consequence, and I hope that there's opportunity to rectify that, to give a chance to the rare disease community.
And Tamar, as we kind of close out here, your passion for health equity and rare diseases, it really just comes through talking to you. But tell us a bit about what just keeps you going. What keeps the fire in the engine to keep fighting for rare disease patients? It's
every time I talk to one of our patients, right? Every time I talk to a patient and they talk about their story and how they have improved their lives, how they have more fulfilling lives, how a person who with HPP, your bones break easily. You can hit your arm against the arm of this chair, and now it's broken, and you have to have five surgeries to repair. To know that a patient who has HPP can do that, be fine, pick up his kid, pick up the two twins. In fact, we saw pictures of the twins and them on his chest. That's, to me, that's nirvana, right? That is the moment that we all live for, is to be able to see patients living meaningful, active lives. No one wants to have a caregiver. No one wants to be 27 years old and being cared for by your parents. That is what I strive for, and my team does every day, is to ensure that every single patient in the rare disease community gets that opportunity to have the value in life that we all experience sitting here today.
Tamar, thank you so much for your time and for the conversation.
Thank you.
Now, for our next session, Changing How Hep C is Treated in U.S. Prisons and Beyond, please welcome to the stage Sonia Kanzader, Associate Director of Infectious Diseases Initiative at the O'Neill Institute for National and Global Health Law, and Adjunct Professor of Law at Georgetown University Law Center, Senator Bill Cassidy, the Ranking Member of the Senate Committee on Health, Education, Labor, and Pensions, Dr. Francis S. Collins, Special Advisor to President Biden for Special Projects, former Director of the National Institute of Health, and Senior Investigator of the National Human Genome Research Institute. And Congressman Hank Johnson, Ranking Member of the House Judiciary Subcommittees on Courts, Intellectual Property, and the Internet, and co-chair of the Congressional Hepatitis Caucus. And to moderate this discussion, our very own Nicholas Flurko, who is our commercial determinants of health reporter at STAT and has been doing a blockbuster amount of reporting on this subject. Nick, go right ahead.
Thanks, everybody. I am thrilled to be having this panel because this is a topic that, frankly, I think doesn't get a lot of attention in Washington, but I think that's starting to change, and I think it might change a lot even tonight. So I'm really excited to have this incredible panel of experts on this topic. I just want to note that Representative Johnson at this point apparently is still at votes for the House as a working legislator. So if he joins us, we will certainly have him at the end of the panel, but otherwise we are going to get started. So in advance, just because this is a topic that I think is not as well known in DC, I just want to give a little bit of brief background. So hepatitis C, for those who don't know, is a blood-borne infection that since late 2013, 2014, has been curable with a once-daily pill. But if left untreated, it can lead to severe liver damage, liver cancer, and death. The virus most commonly spreads through risky behaviors like IV drug use, and it unequally impacts the incarcerated population. It's estimated that between 12 and 35% of people who have been in prison have hepatitis C, while less than 2% of the overall U.S. population carries the virus. But as STAT showed in a recent 8-part series, Death Sentence, people in prison are not getting access to these cures. We found that more than 1,000 people died of hepatitis C in the 6 years, hepatitis C-related causes in the 6 years after these curative drugs hit the market, and that prisons were treating just a fraction of the people that they knew to have the virus in their care. So at least a dozen states in 2021 were treating less than 20% of their hep C positive population, and a number of states like Indiana, Iowa, Nebraska, West Virginia were treating less than 10%. And one of the figures that really struck with me that I'll share tonight is that South Dakota, which housed 382 people with hepatitis C in 2021, treated just 7 people. So I should say we're talking about prisons and beyond. There's also a lot of data showing that these inequities exist outside of prison. Recent peer-reviewed article from the CDC found that 23% of those on Medicaid didn't start hepatitis C treatment, or just 23% started hep C treatment within a year, and that black Medicaid beneficiaries had lower treatment rates than white Medicaid beneficiaries. So with all of that background, I'm hoping to start with Senator Cassidy, because what your title doesn't show is that in addition to being the top Republican on the Senate Health Committee, you were also a liver doctor that, as I understand it, has worked with the incarcerated population. So I'm curious for your thoughts about these statistics and these findings, and frankly, for your thoughts on why these sorts of inequalities exist.
So, Nick, you notice that a liver doctor, the technical term is hepatologist. But when you say hepatologist, people think you either do snakes or venereal disease. So, and so he just gravitated directly to it. I started the hepatitis treatment program in the Louisiana penal system, and they were under a court order to treat. We could do kind of a back of envelope, and I think we thought we had like 20,000 people that needed to be treated. It was just remarkable. And at that time, treatment in $2,000, I think, was $35,000 per. So just that was just going to be overwhelming to the budget. And so they asked if I could come in with a protocol that would help to treat. Now, there's a lot in there to help. First, the prison did not have their own treatment doctors, number one. Number two, they have a limited budget. If they're going to buy the drug, it means that the state is going to appropriate money. And number three, you can't, to understand treatment in prisons, it's not like one of us goes to the doctor and we walk in and we wait and we sit and then we go in. No, if you have somebody on death row at the prison where I was, they cleared out all the other prisoners. They brought him in with 3 people guarding him, and you had this, they had a guard in there with a gun and another guard without a gun to undo his thing. The logistics of managing such patients, the security, makes it more difficult to treat. In some cases, states are not treating because they don't have the money. In some cases, they're not treating because, frankly, they don't want to. In some cases, they're treating, but it's much slower than you would imagine because the logistics of treating in a prison is very different than the logistics of someplace else. I did this for 2 decades. I know of which I speak. Now, in terms of all this, now that was back when we were using shots, which were relatively not very effective, and now we're giving pills. It's much simpler. But you still have the expense, and you still have the logistics. Lastly, I will say that the contribution, one last contribution I made to treatment of those in jail was to collaborate with people back home. This was headed by a woman, Rebecca Gee, who was our physician in charge of Health and Human Hospitals at the time. And we spearheaded what was called the subscription model or the Netflix model. Netflix, we all know, some college student wants to watch, I don't know, Planet of the Apes, and they just binge over the weekend. So the idea is that you would give the drug company a certain amount of money and you would treat as many people as you possibly could. They really had success in the first year. The pandemic hit. You can imagine that really made logistics difficult, and the numbers plummeted. But there are models in which you can lower the per-person cost of treatment, and the pills are much easier to administer. You don't need a hepatologist. You can have a physician, nurse practitioner, et cetera. And I do think it's more achievable now, but there's still the expense, there's still the logistics. It's always going to be a difficult population.
Thanks, Senator Cassidy. And I should say it wouldn't be a Stat and DC event if we didn't talk about drug pricing in every panel. So I definitely want to ask you more about the subscription model. But before we do that, Sonia, I'm curious for your thoughts as to sort of why the inequities exist in treatment rates, sort of what you've seen in your research.
Yeah, thanks for having me, first of all. The reason that we're seeing some of the inequities, there's a lot of different factors. So access to healthcare generally, just being able to get healthcare coverage is a challenge that we're seeing with getting the access to treatment. Obviously, the drug costs have been a significant concern for a long time, and another factor, quite frankly, is the population that is disproportionately affected by hepatitis C right now are those who are also dealing with substance use disorder largely, or that are somehow affected with substance use disorder. And so they're also compounded with usually collateral issues of experiencing homelessness or economic insecurity, healthcare insecurity, and then there's just a general kind of social stigmas associated with substance use disorder that malign their ability to interact with the healthcare system and the social service system and access the care that they need. You hear a lot of negative interactions that they have sometimes with the healthcare system, even when they try to get care for themselves, and so it becomes a deterrent, even when they want to engage in care, for them to be able to do so. So that's just some of the factors I think that I could probably keep going, but I won't. But there are lots of different significant factors that play into that. But really being able to access health care, be it through the Medicaid program, Medicare program, but also making sure that there are barriers removed even once you have that care, in order to get the hepatitis treatment, so even if you're on Medicaid, making sure that the Medicaid program in that state is not imposing additional sobriety restrictions or prior authorization restrictions is yet another hurdle. So sometimes these people are facing one, well, I don't even have health care. Okay, once I get health care, well, then they still won't treat me because I haven't gone to the right doctors or I'm not sick enough. And another thing that Senator Cassidy mentioned too is, or started to discuss, is just the bandwidth, the capacity for providers to even treat. The demand for hepatitis C treatment, we're still kind of having some issues with that, with doctors having the skill set or having the comfort to treat with the direct-acting antivirals. A lot of them are still not, think that they need to refer patients to hepatologists, where no, primary care physicians more and more can treat with DAAs very successfully. So getting that information to be more widespread is essential as well.
So, Dr. Collins, after you left the NIH, it seems like you've dedicated quite a lot of your time to trying to solve all of these issues that we're talking about. So I was hoping you could sort of get the audience up to speed on your work at the White House on hepatitis, and frankly, why you decided that this was going to be the big thing you were focusing on after leaving the NIH after all those years.
Well, first of all, it's a privilege to be on a panel with these folks who've worked so hard on this. Senator Cassidy's been a true champion of bringing to public attention the opportunity and the responsibility to see what we can do. Because how often do we get a chance to cure a disease? That's where we are. And Sonia Canzeda, with all the work she's done, just mentioned a little bit of, but there's a lot more that she's been involved with at the O'Neill Institute, really bringing this to attention the way it hasn't had that attention. Hepatitis C, people are like, oh, I don't know what that is. And our terminology is not great because we have A and B and we have C, and it's easy to get them all mixed up. But they're all about people. I'll tell you about my brother-in-law, Rick, who's an incredible, dedicated father, outdoorsman, built his own boat, was incredibly creative in all sorts of ways. And he got sick, and nobody could quite figure out what it was. And it turned out he had hepatitis C. And his liver began to fail, and this was 15 years ago, before the highly successful oral agents were available. And ultimately, his liver failed. He needed a transplant. He waited way too many months for that. Finally, at sort of death's door, got the transplant. Shortly after that, discovered he had liver cancer. And he died a really awful death. We can't look the other way. If that is happening now, and we have a way to prevent it, and we're not doing it. So these direct-acting antivirals for hepatitis C are one of the most dramatic achievements of biomedical research in the last 20 years. One pill a day, 8 to 12 weeks, essentially no side effects, 97% cure rate, and you're done. The virus is gone. You don't have to take this the rest of your life. You are cured. And yet there are 2.4 million people, probably more if we had full ascertainment, in the United States right now who are chronically infected with hepatitis C. 40% of them don't even know. And they are ticking time bombs for what happened to Rick. And we have the chance to find them, to test them, and to cure them. But yet, many of them are in marginalized communities, as you have heard, in a place where they're not getting that access. So what do we need to do? It's one thing to wring our hands. What do we need to do? One thing we need is a point-of-care testing capability. So you could do testing and start the cure the same day. Right now, it takes you 3 clinic visits before you can get going. So you need that kind of testing capability. We know how to do that. We figured that out for COVID. Why can't we do that for Hep C? We could. And that would, particularly for people who have trouble with transportation, getting to the clinic, asking people to come 3 times, we just lose them along the way. That's one thing. We need to figure out how to make this affordable. I mean, my heart goes out to people in the prisons who really want to do this, but when they look at the budget cost, if they're not in Louisiana, if they haven't followed this remarkable model that Senator Cassidy championed, the prisons are like, you know, we just don't have the money to do this with a cost which is currently about $24,000 per patient. That's just something we have to fix. And this subscription model the senator talked about is my favorite way about how to address this. Everybody wins. The companies right now, and it's Gilead and AbbVie that have the FDA-approved oral therapy, they're not making any money on these marginalized communities because nobody is getting the drug to them. So suppose you make a deal, a lump sum, and once that's agreed to, the companies make the drug available for free to anybody in prison, anybody on Medicaid, anybody who's uninsured getting their care in a community health center, anybody on the Indian reservation, anybody who's in an opioid treatment program. Those are opportunities that your program in Louisiana said that model can work. But why don't we do it for the whole country? I think that's achievable. And then we do have to recognize it's not just about the price, as the senator said. It's also the logistics about how do you actually get people to the right place, do the testing, educate the providers so that they're not afraid to get into this space. And my experience with providers is once they've had the experience once or twice of finding out I can cure somebody, they're like thrilled with that. The previous treatment of hepatitis C was awful. It was interferon, and that's in a lot of people's mind, and they think, oh, that's what I've got to do. No, this is like one of the more satisfying things as a provider you could do. So, but we have to get people educated to do that. So why not come forward with a plan? When I became the science advisor, oh, welcome. Thank you, Doctor. Good to see you, Congressman. Congressman Hank Johnson from Georgia, a hepatitis survivor, and we'll hear about that in a minute. I'm going on a minute, but I'm not going to go on too much longer. So when I became the science advisor, the acting science advisor, and sort of looked around to say, are there things that we could be doing as a government that we're sort of not somehow bringing all together? And I talked to multiple government agencies. I brought on board an amazing health economist as my senior advisor, Rachel Florence, who's here. We talked to Medicaid folks in the states. We talked to the advocates, and it became pretty clear. Everybody wants to do this, but there's not sort of a coherent program. We talked a lot to Senator Cassidy and his staff. We talk almost every week about that to try to figure out this is going to work. It's going to have to be something that the executive and the legislative branch put their heads together and make it happen. And while I can't get ahead of the president's budget rollout, which is, of course, on Thursday, it would not be appropriate for me now with my appointment as a special projects advisor to the president to do that. I think I can tell you that there will be a call for significant investments into tackling the hepatitis C challenge for our country and to all these places that are currently not getting the cure that they need. So watch that space on Thursday. And the final thing I'd say, I think I also have to point out to you, if you haven't noticed already, this fits nicely with the cancer moonshot because this is now the most common cause of liver cancer. Liver cancer is one of the cancers that's going up when others are going down, and most of that's hepatitis C, and we can prevent that. How often do you get to do that? Okay, sorry.
Thank you, Dr. Collins. Well, that was both a great summation of all that you're working on, and also it sounds like there was some news in there. It sounded like you were saying that we should see a call for some funding for Hep C in the budget. Is that correct?
Wait till Thursday.
Okay. Representative Johnson, thank you for joining us. We had just gone through, we spoke to Senator Cassidy about his experience as a doc and Sonia about her experience about why inequalities exist. And I'm hoping, with the audience I shared before the inequalities that exist in Hep C care, some of stats findings that, over 1,000 people died of hepatitis C-related complications in the years since hepatitis treatments hit the market. And I was hoping to get your take on sort of the current state of hepatitis C care, and if you could explain to the audience sort of how you got involved in this work.
Well, I tell you, it was February of 1998. So it was 25 years ago, and I'm giving up my age now. But, 25 years ago, I was told that you have hepatitis C, and you can expect to live another maybe 20 years or so, at which point you will definitely need a liver transplant because of either cirrhosis of the liver or cancer of the liver. And so it was kind of, and there's no treatment for it, they said, other than ribavirin and what else was it?
Interferon.
Interferon. And only 25% of the people who take that therapy clear the virus. And by the way, the side effects are horrendous. So that's what I was facing. And but anyway, fast forward to 2013, after 4 rounds of treatment and a year having gone with my blood being free from the virus, or the virus not being detected in the blood. It was around January of 2013 when my doctor pronounced me as cured after 4 rigorous regimens of treatment. And today, 12 weeks, 1 pill a day with no side effects, and you're cured. I mean, it's just, and the cost back then, I think, was probably, I don't know how much my 4 rounds of treatment cost, probably at least $500,000, I would speculate. That was just one person. But today, costs are down, and now we have an incubator, the prisons, the jails and prisons, where we have drugs that are flowing like folks are on the street, and I know because I was a criminal defense lawyer, and needles for purposes of injection, and also for tattoos, being rampant, and so we've got people in jails and prisons. It's the incubator for the spread of hepatitis C. The rate of people in prisons and jails with hepatitis C vastly exceeds the percentage of the general population that is not incarcerated. And so why not test folks when they're going in? Because we do have a lot of recidivism. I mean, recidivism is a fact. So why not test when folks go in, and why not treat while they are in the incubator, so that the 95% of them who are one day coming home are not spreading it once they get home. And if we can attack hepatitis C in the jails and prisons aggressively like that, testing and treating everybody, then we cut down on the transmission. We have a shot at being able to do a moonshot with hepatitis C, which I hope is going to be announced on Thursday with funding to go along with it, and finally relieve us of the scourge of hepatitis C and the costs associated with it, which each and every one of us as taxpayers are saddled with, one way or the other.
Thank you. I want to talk as much as we can about sort of national hepatitis C plan, and I know you can't get ahead of the president, Dr. Collins, but when I've seen you speak previously publicly, you've talked about sort of the price of something like this being about $8 to $10 billion and potentially saving magnitudes more than that. Can you give us a sense of how big of a plan you're thinking about, even if you can't say it's going to be definitively in the budget, just to get a sense of how big of this might be?
I think that was a hypothetical piled on top of a hypothetical. So, yeah, I have, of course, been working on this along with many colleagues who have worked on it longer than I have. And yeah, a big shout out to my good friends at CMS and at HRSA and at CDC, at SAMHSA, at the Indian Health Service, the Bureau of Prisons. All of these folks have been engaged now for many months in multiple high-level conversations about how to do this. And again, I would like, if it's possible, to be as bold as possible and to actually contemplate not just an effort that would improve the situation, but that would eliminate hepatitis C in the United States. That's a big, scary word, and obviously would require a huge investment to try to reach everybody. But I don't know why we couldn't take a shot at that. Again, the costs are going to be partly unknown because Right now, we don't know how good a subscription deal we could arrange with the companies. We know Louisiana came up with a good one with Gilead, and Washington State came up with one with AbbVie. So the model is there, but I don't know what the dollar figure will be. A lot depends on that, obviously. We have an idea what the cost is to support the logistics in the prison system, at least the federal and the state. The local jails is going to be really hard because there's much more quick turnover and less medical staff. I think we know what we need to do for the community health centers to help uninsured people, including many of the homeless, and maybe have things like mobile clinics to actually go to where the people are instead of expecting them to turn up at some brick building. I think we also need to know what it's going to cost to have this testing capability. And I think, in Europe, there is already a point of care RNA test on a finger stick that tells you whether you need to be treated. Cepheid has that. It has not been approved in the US. We need to speed that process up. FDA and NIH working together in a good position to try to do that. That'll cost some money. So all of it's pretty fuzzy. We hired a couple of economists at Harvard and Stanford to work through this. They came up with some numbers. Everybody else will come up with some other numbers. What's going to matter is what does CBO say? That's what the Congress is going to want to know, right, Senator? Is this something that actually looks like it could be afforded? To get into the weeds a little bit as far as how this would be funded, ideally, many of us think this would be funded as a mandatory fund, not a discretionary where you have to go back every year. Do it in 5 years, figure out the cost, put it forward. If it's going to pay for itself, it's much easier for Congress to go along with it. If it's going to cost some money, then you have to find offsets, and that's what people do. So you're going to have to get into that part of it. The CBO score is going to make a big difference. I'm not going to go further than that about numbers.
Sounds like we're talking billions, though. Is that fair?
You said billions, I guess.
I asked this because I really want Senator Cassidy's thoughts here. Frankly, whether conservatives in Congress, you think, I know that you understand the value of hepatitis C treatment, but we're talking about billions of potentially mandatory funding. What's your thoughts on whether that's the sort of thing conservatives could get behind?
It really depends upon the faith they have in the model. Conservatives care about life. We're pro-life. We care about folks who have been disaffected. That's been my practice. But sometimes you see models and you realize that the models is kind of, as my wife used to say, she's a general surgeon, speaks this way, as if it's constructed with flatus and moonbeams. The structure of the model just seems kind of like not to be there. Now, we did some preliminary modeling, much less sophisticated than what they're doing, but this could actually pay for itself. If you look at the cost of a liver transplant, $150,000, the end of life, the last year of life of a patient with advanced liver disease, that would be probably $100,000. The therapy that somebody is on once they have a liver transplant is going to be tens of thousands with the testing, et cetera, the follow-up. It gets better over time, but it's really expensive to manage an end-stage liver disease patient. Now, what I don't know is if in the 10-year window you pay it off. And the mandatory spending would not be mandatory spending like Social Security for ad infinitum. It would be for a period of time in which you're Now, by the way, I'm not necessarily endorsing the mandatory spending aspect. But as I understand the program, it would be mandatory spending for 5 years, and then it would stop. And so it's also kind of limited. So to kind of summarize, if you have a model which saves lives, which saves money, which gives us better outcomes, and you can do it in the 10-year window, that's something we should endorse. If it's not in the 10-year window, it takes a little bit more of a selling job, but it really depends upon whether that model is constructed in a believable way or unless it's constructed with assumptions that people find harder to believe.
Representative Johnson, I'm curious for your thoughts on this. As the co-chair of the Hepatitis Caucus, I'm sure you talked to a lot of your colleagues about this topic. What's your thoughts on whether this sort of thing could pass the House, frankly?
Yeah, last year's defense budget was $875 billion, something like that. And we actually appropriated $25 billion more than the president's budget request. In other words, $25 billion in political add-ons to an already Some would say bloated, others would say necessary, somewhere in between maybe most of you all would fit. But the numbers, don't lie. $25 billion now, how much would a moonshot, I don't know, how much would a moonshot on hepatitis C over a 5-year period cost? I've heard, and I don't know where I heard this, but I heard like $10 billion, over 5 years. That's like a drop in the bucket, in terms of doing something to eradicate a disease that is very expensive, eradicate it in our country, eradicate the disease and the cost of the disease. So in my mind, it's like a no-brainer. We should have done this last year. We should have cut the defense bill, the extra $25 billion. We should have done the $15 billion. If we just had to do it, do 15, and then kick a $10 billion, allocation to this very worthy and worthwhile objective. So, in this day where folks are looking for places to cut, though, and they've already said no cuts to Medicare and Social Security, which are the big pots, so where will any cuts be produced? Don't know. Will we be able to add on something that the administration has proposed in their budget? I don't know. I hope so. If not now, then in the 119th Congress, we can get it done.
Sonia, you're the one of the policy experts, I should say, on this panel. What are your thoughts as to sort of first, your thoughts about a national plan, and also just what things should we be keeping in mind, knowing the examples of different states and their efforts? Like, what are the important things that you think should be included in this plan or should be top of mind?
I'm very excited about the prospects of a national plan that would really just bring together a lot of the best practices and successes that we have seen in smaller pockets in different jurisdictions, and really just, as Dr. Collins has said, just spread cure across the country and get it to everyone who needs it. Some of the things that I think need to stay top of mind is certainly what we're talking about here. We really need to, I think the congressman spoke of the need to amplify treatment and corrections perfectly. The amount of people who go through that system, it is just an under-tapped opportunity to engage people in diagnosis and treatment, especially those who are at greatest risk, some of the greatest risk for hepatitis C in our communities, people who are intersecting with substance use and substance misuse, and who are kind of churning through the justice system. It is a great opportunity that is needed, and we cannot ignore that aspect in order to achieve elimination. It won't be done if we ignore that aspect. And expanding Medicaid, those states that still haven't adopted Medicaid expansion need to, if they want. The irony is some of those states are the ones who have a lot of the rates of hepatitis C that are going unmet and untreated because their communities cannot access health care. And so promoting further expansion of Medicaid and removing those Medicaid restrictions related to requiring people who have substance use disorder to be sober for a certain amount of time, requiring them to see a specialist, requiring them to get prior authorization, removing those barriers is essential in order to move this forward. So that needs to stay top of mind, and that needs to, and I'm very glad that Dr. Collins also mentioned the need for that point of care, that one-stop shop testing, being able to get the confirmatory diagnosis and immediately getting your drugs and getting into care, getting rid of that three-step process that is just decimated. It's just causing so much loss to follow up and people staying undiagnosed. So I think if we can focus on getting people diagnosed. Getting access to the drugs is wonderful, but we have to know who needs them. So we have to really amp up and promote prevention. It's best for people just to not get sick in the first place, as well as letting people know their status. That 40%, almost half of the people with hepatitis right now don't even know that. So getting them to know their status and immediately getting them treatment. We can't let people know that they're sick and then kind of shrug our shoulders and say, but we don't have a recourse for you to actually engage in your treatment. So we have to make sure that we're covering all of those. And I have no doubt that the plan has all of that top of mind, which is why I'm just so excited by that.
I think we have a question from the audience.
I've seen at least 3. So the first one right over here, I'll ask that the people asking questions keep their questions short and make sure they are questions.
Thanks very much. Hi, Tim Leshin with the Schools and Programs of Public Health. I want to pick up on Sonia's remarks just now. Before that, let me just say how appreciative I am of this panel and what you're trying to do here. It's so important. And I want to say this is a classic public health problem, right? We know what the problem is. We know what the treatment is. Now we have to figure out who the people are who need to get the treatment and how quickly. And I want to ask about the public health perspective here. How are we going to make sure we're funding that part of this equation? Because that's going to be essential too.
Thank you.
I think that's a great question, Tim, and I think that has to be a component of any program that's going to have credibility. And I heard the senator say it's got to have credibility, not just some hand-waving, let's hope it works kind of thing. And that means it's going to have a leadership that is fully imbued in how you get things done. It's going to have an amazing dashboard so that you know when you start this program actually who is testing positive, who's getting the drugs, where's the drug pipeline. All of that's going to have to be done in the most rigorous way. And let's be clear, we don't have a great track record always of achieving that, and this has to be a part of the program or it's not going to succeed.
But we do have examples of where this has worked. Under the Vaccines for Children's program, the most expensive item in vaccinating children was the vaccine. I say that because we ended up putting together a program. We vaccinated 36,000 school children at no cost to the mom or to the school. So once the VFC took out the cost of the vaccine, you could put together a public-private partnership that executed. Now, it takes local leadership. Now, sooner or later, VFC got kind of integrated into the pediatric practice. But for the catch-up immunization, and what we're really talking about here is catch-up treatment. For the catch-up immunization, it's going to take local and state leadership. It cannot be something directed from D.C., or it'll just be dollars pouring down to the state, and at the end we'll be thinking, what in the heck just happened?
Before we go to more audience questions, there was one thing I wanted to follow up with you, Dr. Collins, when you were talking, when I was asking you about cost, you mentioned a subscription, and I just am wondering, are you envisioning a nationwide subscription? And frankly, how would the logistics of something like that work? Just because in my reporting, for example, like a lot of the inequalities we see are state prisons. Like, is this the sort of thing you envision the federal government essentially procuring drug and giving it to prisons? I'm just curious how that might work.
I think not to procure it. I don't imagine this is the federal government getting pills in a warehouse and then figuring out how to send it out. That's not the model. It's basically doing a subscription model with the suppliers, one or both of them, and then at that point, the supplier is on notice. Okay, if a state prison says, we have this many people who are testing positive, they have to send the pills to them. I don't want the federal government to be a middleman.
Got it. Okay. And can I just ask, have you had conversations with drug makers about this?
Yes.
Are they amenable generally?
I don't want to overstate their level of enthusiasm, but I think they're extremely interested. Again, recognize right now they're not making any money on this group of underserved patients who are Hep C positive. This is a win for them.
Dr. Cassidy, I'm curious for your thoughts of your subscription model potentially going nationwide.
Again, I think it's a great potential. In the prison system, you have a healthcare network that can do it. That's where the VFC analogy works really well. Now, outside of the prison model, then you're talking about community providers. Oftentimes, the Medicaid practice is a high-volume practice, and so it becomes a little bit more difficult to do the counseling that may be required. But if you have state and local leadership that drives it, Dr. Gee did it in Louisiana with our Hep C program, you got to have that sort of commitment on the state and local level. Alaska is different than Rhode Island. And so whatever you do has got to have a kind of like, okay, you guys figure it out.
Sure.
We have a question over here, a quick one.
Yeah, my name's Steve Cohen. I'm a general internist, and I just wonder if you think that CMS could, say, leverage its position to increase screening for hepatitis C. For example, healthcare systems are penalized if people haven't gotten their pneumonia shots. You could ask them to do reports if people haven't been screened for hepatitis C. When I do an annual wellness exam on a Medicare patient, I've got to say, are they depressed? Are they smoking? It would be easy to say, okay, have they been tested for hepatitis C, yes or no? And that, I think, could significantly increase the screening rates.
It's a great question, and we've had lots of conversations with CMS, including Mina Seshamani, who was here on the earlier panel. And I think there's a lot of interest in coming up with ways like that wouldn't necessarily require legislation, but would require CMS to take a more active role, and they're extremely interested in doing so. So all those conversations are happening at the same time we're imagining this national program.
But again, if you cost it out, cost-benefit ratio, you're 1% to 2% in your Medicare population. And some of those are really a very low risk to have complications. Most people with hepatitis C will die with it, not die of it. And by the time you're 65, you've probably had it long enough to declare yourself. Now, if we're speaking about the population which is highest risk, which is men and women 15 to 35, used to be, probably still that way. Now, there it's a 15% prevalence in some subpopulations and higher in the prison. So your cost-benefit ratio really adjusts depending on that.
We have a final. Want the test to be really cheap.
Yeah.
We have a final question back here from Rick Burke.
Fascinating discussion. Each of you have such a unique, absorbing perspective on this. I have a question. You're talking about cancer moonshot and how this would be the next moonshot. Dr. Collins, I'm curious how, we know President Biden is very engaged in, obviously, the cancer moonshot. How much is he aware, interested in this effort?
He very much resonates with all of the principles we're talking about here. It's the means to prevent a common cancer. It's a means to address health inequities. It's an opportunity to actually, over the long term, reduce the deficit. Because, the VA did a study recently. VA, by the way, has done this. They got money from the Congress some time ago, and they found roughly 90% of veterans who are Hep C positive and cured them. And I just saw a report a couple months ago. The estimate was they saved about $69,000 per patient that was cured.
And they were paying pretty top dollar for the drug.
And they were paying top dollar for the drug. That's right. So it's, in the long term, this is the way to reduce federal spending on Medicare, Medicaid, and the VA, but we have to pay something up front in order to reap those rewards.
We know how interested he is in science. Is he conversant in Hep C and what's going on here? What you're talking about?
I would say yes, but you can define conversant any way you want. I don't know that he would have given the same description that I just did this evening about the various components of the program. But yes, he's very conversant of science.
And one final question. Nick is too modest to say this, but you all have spent your careers on this. Nick spent more than 2 years investigating Hep C in prisons, state prisons across the country, revealed that more than 1,000 people died that didn't have to die if they could have had that access to this miracle pill. I'm curious how much that, when the history of this Hep C moonshot, if it happens, is written, what will Nick's role be in it? As his boss, I have to ask that.
He'll be in the honor roll, that's for sure. I think his stories, and if you haven't seen them, they're really powerful because they're human stories of people who lost their lives unnecessarily and all the crisis that didn't have to happen. That, I think, visibility of the problem and humanizing it helped get more people to start thinking about the need to do something.
There's a Pentecostal minister I know. He said, "Nothing is more powerful than an idea whose time has come." Nick, with those articles, has helped the time come.
Thank you.
Thank you.
Okay, I know we're over time, but I can't let it end just on that. I want to just ask quickly, Representative Johnson, what's your take on, has the time come? You are the chair of the Hepatitis Caucus. You deal with awareness all the time. When you're talking to your colleagues, is this the sort of thing that people are now aware of?
Gosh, I really can't give you an honest answer on that, but my pledge is to do my best to make sure that we can answer that affirmatively the next time you ask the question.
Sounds good. Thank you all so much.
All right,
Thank you.
Thank you.
What a wonderful panel. Now, for our last session of the evening, the landscape for healthcare policy in 2023, please welcome to the stage Javier Becerra, Secretary of the U.S. Department of Health and Human Services, and to moderate, Stats Sarah Overmall.
If not, I have one for the second.
Yes. Okay. There is a book there, but do you want to?
Go to the middle. You're the star, so.
Thank you all for staying here for this panel. It's a bit toasty in here. Appreciate it. So we're going to jump right in because I have a lot to ask you about, and I want to start with something that is obviously taking up a lot of attention in the country right now, which is abortion rights and access to abortion and reproductive health care. Vice President Harris recently convened reproductive rights advocates to talk about what we will do, she said, quote, to talk about what we will do to highlight this issue to make sure that people in America are aware of what's happening. Is that all the administration can do right now, is raise awareness on this?
No, we've sued states to make sure that they continue to have access to abortion care where they need it, especially in cases of emergency. We have put out a clear definition of what the rights and opportunities are for folks who are in states where their rights are now being abridged. We have worked closely with a number of states and a number of organizations to make sure we continue to provide family practice services through the Title X funding. We will continue to make sure that abortion medication is available for every woman in this country. We will defend a provider's right to exercise the skills and training they received in medical school to provide a woman with the care they need. I can keep going if you want, but no, there's a lot that we're doing, and we'll do what we can within the federal structures and the federal laws that we have, but the president was very clear. We are going to make sure that under his watch, we increase access to care, not actually decrease it and take away rights.
So getting more specific on that with the abortion pills, it's called mifepristone, and the looming decision in Texas, which could take it from market, however temporarily. If that happens and it is pulled off the market, what is your plan at HHS?
So everyone thought by now we would have had a ruling from that judge. My suspicion is he's beginning to read the law and get a better idea about this and understand the impact he might have on not just this medication, which has been around for 20 years successfully, effectively, safely, but he's also realizing that he may put in jeopardy a whole lot more than just mifepristone. But there are a whole bunch of medications out there that went through a very similar process at FDA. This is an evidence-based process. The decision was based on all the scientific data that we compiled, and for 20 years, guess what? FDA got it right. So maybe he's actually looking at the facts and the law.
But if he does rule that it's unsafe, what happens next?
I'm not sure what world we have to live in to try to get, this country to move in the direction of actually protecting rights versus dismantling those rights. But we will do what we have to do. We will certainly look at any decision that comes out. we're going to protect a woman's rights to have access to reproductive care, including abortion care, and it should include any medication which has been proven effective over the years and through the science and with the evidence. But we'll do what we can, and I'm giving you a very oblique answer because I don't know what the judge is going to say. He's one person, and there are a whole bunch of folks in this country who just are ready to stand up.
Relatedly, I mean, the administration recently made it more easy, or actually allowed pharmacists to dispense that pill, but there's been some lack of clarity around whether pharmacies will do that in states where it's restricted. Do you see a role for HHS in approaching that?
Well, FDA is HHS, and so what HHS has said is that done right, that medication should be available to be dispensed at a pharmacy. There are some pharmacy companies that are stepping forward saying that they want to try to do that. We'll work with them to make sure it's done safely and effectively. Nothing changes. Again, it's got a 20-year track record. It's not as if it's some new medication that hasn't been tested. It's tried and true. And you can talk to a good portion of this population who can tell you that it worked the right way and kept them safe.
So switching gears, there have been reports recently that the administration is tightening its policies on migrants at the Mexican border as it prepares for Title 42 to end with the pandemic emergency. And the New York Times recently reported on an internal staff meeting where you said, quote, "This is not the way you do an assembly line. Kids aren't widgets, I get it, but we can do far better than this." First, what did you mean with that, and what were you pushing for?
Thanks for asking me the question that reporter wasn't willing to ask me, because we could have explained that at that particular time, we were trying to figure out how we could come up with a process that would be handled efficiently, because we have a responsibility not only to care for that migrant unaccompanied child while they are in our custody once we've taken them from the Department of Homeland Security, but we have an obligation to, as quickly and safely as possible, place them in a different setting. We keep them in congregate care settings. That's not the place you want to keep a child for very long. And so we make every effort to find a responsible sponsor who will protect them, care for them while they are going through their immigration proceeding on asylum. We typically look for the closest relative we can. Oftentimes it's the parent. Sometimes it'll be an aunt, uncle, older sibling, grandparent. But we try to do everything we can to place them with a responsible, vetted sponsor. And what we have to do, though, is make sure we're moving responsibly so that child gets the best care. The child probably has suffered enough trauma. And so our job is to do it efficiently. We would have days when we were doing very well in getting some of these kids discharged into the hands of a responsible sponsor. There were days where we weren't doing so well. And what I was just saying is, you can't have a process work where one day you do very well and with the same number of people working, you don't. Because if we don't do well all the time, then those kids end up staying in an adult detention facility with the Department of Homeland Security. Our job is to put those kids in the safest environment we can find. If we can't find a responsible sponsor, then they stay with us. But they should not stay in what is an adult detention facility with the Custom and Border Protection Department.
So with anticipation that there could be a surge of migrants at the border when the emergency ends, how is HHS preparing for its role in that?
So through these last couple of years, we've worked really hard to be able to absorb, in 2 years, about 280,000 kids. How many kids have you raised? We have seen about 280, and by the way, your kids probably get a good dinner at night. They are ready to go to school in the morning. They get to sleep in a nice bed. The 280,000 children we deal with don't get to experience that very much. And so we work really hard to try to do what we can. All of our facilities now, whether they are licensed care facilities, very similar to what you see in a foster care setting, or whether it's because there aren't enough licensed beds for us to be able to put with these migrant children in. And so we had to, 2 years ago, you probably saw the news where we were having to open up convention centers because we needed to place them somewhere. Otherwise, they stayed in CBP, and some of you saw the video of kids sleeping with those foil blankets on the floor. So we had to figure out what to do. And when there weren't enough licensed beds, we did what we had to do, find a place that could provide them with more. Obviously, a convention center is not a place where you want to raise a child. But when you run out of licensed beds, you try to do the best you can. And by the way, in that process of trying to find a place to put them, we're also trying to figure out if there's a sponsor. So we're doing all these things at one time. And believe it or not, 2021 and 2022 were very instructive, because today, 2023, rather than have 18, 20, 22,000 kids in our care, we have less than 8,000 that are in our care. All of them now can have an opportunity to be in a licensed care facility if they're staying with us for a little while. But most of them we've been able to process through, so we find, in virtually all cases, a family member that we can place them with. We can get into what the article found about what happens to these kids even once they're placed in the hands of even a mother or an aunt. And that's the difficulty of the situation is in. And my final comment is, by the way, guys, let's not be naive. When you're dealing with a broken immigration system, year in, year out, guess what happens? It's just exactly this. And I don't understand how an employer can look at one of these workers that's 12 or 13 and say, you're ready to work. But that goes on in America. And I wish my arm could reach and say, we're going to do more. I'm HHS. I'm not law enforcement. I'm not Child Protective Services. I'm not the schools. We got to figure something out. But this is the consequence of a system that allows immigrant children to walk past the border without an adult accompanying them, and then the rest is history.
I'm sad to move off that topic, but there's a lot more to cover. And this is also in the realm of, pandemic era provisions and changes. It became easier during the pandemic for people to access the opioid addiction treatment, buprenorphine, through telehealth. DEA recently proposed a rule that would actually reverse some of those telehealth, or would make it so that people would be required to go to their doctor to continue their prescription. So first, what are your thoughts on that? And just, do you think the DEA should be regulating this like that?
Well, so what's happening is, with the public health emergency coming down, we're going back to the world before the public health emergency. So the world February, March 2020, which did not allow providers, medical providers, to prescribe medications, especially those medications that were on the formulary for a controlled substance. What we're doing, and what we announced, DEA and HHS, is that we're coming up with a rule, and it will be open for public comment, that will allow providers to be able to continue to prescribe in particular cases. And the rule speaks specifically to someone who is approaching a healthcare provider, a doctor, who that individual may never have been to before. And what we're trying to do is make sure, in the cases of opioids or some other level of addiction, that because you may be in a rural community and you don't have easy access to a doctor, or you live in an urban area and you're not very wealthy and you don't have a way to pay, and you therefore don't have quick access to even doctors that surround your neighborhoods, that you're not going to end up ODing. And so this rule is meant to address what we've since learned because of the pandemic, and that is that telemedicine works. And we should try to use it to the degree we can. Now, there's some issues there. You have to have accountability. How do you track if a physician is actually making the right type of prescription or making the right decision if the physician has never met the individual? But what we're doing is putting enough safeguards that what we hope we do is we save lives, and then let's go from there. But there will be still opportunities to do telemedicine, but in this particular case, it's a narrow portion of what has to happen when it comes to prescribing of medications which might be on the controlled substance list formulary.
So to be clear, you're in sync with DEA on that?
Well, we're HHS, and we work really hard with DEA. DEA's mandate is very different from ours. They have to worry about protecting the public from the spread of drugs. So their lens is different from ours. I want to keep people alive. I want people to get off of those drugs. I want to help them. I don't want there to be stigma. And so my push is to do everything I can to use what's worked. Just as we just finished talking about mifepristone, 20-year history of a very effective medication, we've learned that it is possible to prescribe via telehealth and make it work and save lives. And so that's the effort we're going to push. We've been able to have a good partnership with DEA to get to a place where they can feel like they're still going to be protecting the public from the spread of drugs, and we feel that we're going to be able to protect those who are trying to get the medication they might need.
So this is a big week. The president plans to release his proposed budget for 2024. What are your priorities, both personal and HHS secretary, in that budget?
Oh gosh, every time you get asked that question, it's like, name your favorite children, and it's always very difficult, right? So, and you know, it's the great thing about HHS is we're working on so many important things. Can I just start off by saying, I hope that by the time I leave, we've sort of made it very difficult to go back to what things were like and doing things the way we are. My mom taught me way back, I was a kid, mejor prevenir que remediar. Better to prevent than to remediate. We do so much remediating in this world when it comes to health care. We have an illness care system, not a wellness care system. I would love to see us shift towards that wellness care system where we're trying to prevent things like addiction or a woman having to go to an ER room because she wasn't able to get the kind of care she needed and now is looking at an abortion. So overarching, get us to a wellness care system. What does that mean? Well, one of the things the president said fits neatly within that. He promised that he would, on healthcare, he would lower the costs of medicines for more Americans with better benefits. $35 insulin, check. You can get on the Obamacare website. 4 out of 5 Americans found that they could get a health care insurance plan, a real one, not a skinny junk plan, $10 or less a month for their premiums. Big check, big check. Today there are more than 300 million Americans who have health care. Never seen that before. That's the first time in our country's history so many Americans have insurance coverage. And so the president delivered there. We still have more to do. Obviously, we're going to try to work harder to make sure some of these prescription medications are more affordable. It's hard to go anywhere without talking about preparedness. We're not out of COVID. Still having 300 or 400 Americans die a day. 3,000 to 4,000 get hospitalized a day. And so we have work to do, but we're not where we were 2 years ago. So preparedness, continue there so we can always stay ahead of what comes next. 9 out of 10 Americans tell us that America is experiencing a mental health crisis. Behavioral health will obviously be big. The great thing is it's bipartisan to try to do something there. 988, I hope you all know about 988 by now. It is 911 for those who are going through a mental health crisis. And we intend, and with the president's support, we intend to really make sure that 988 continues to work. The good thing is people are calling this new number instead of having to dial a 10-digit number. Now they just dial the 3 digits, 988. Actually, a lot of them don't dial. They just sort of text and chat. And we've seen about a doubling of the number of people. We launched 988 July 16th last year. In that 6 months, till the end of last year, we saw virtual doubling of the number of people who called, wrote, and communicated with us using the lifeline, which is good. It's also very bad that so many people are calling, and they're getting younger and younger and younger.
You teed up my next question by talking about the amount of people who are insured right now and it being at record highs, because Biden and other officials, including you, have warned that Republicans in this budget process could come for certain Medicaid provisions or cuts to the program. That combined with the fact that states can start removing people from Medicaid rolls in April, how are you, as HHS trying to curb the amount of uninsured people that we could see?
So with the Medicaid unwinding that's going to occur, we was somewhere around 15 to 16 million Americans could lose access to health care through insurance. By the way, 1 of every 2 individuals on Medicaid is a child. And so it could be devastating. But we know that many of them will qualify for Obamacare coverage. Well, they just got to know it. And so we just have to make that a seamless transition. And we're working with states and the governors to make sure that that can happen. A lot of folks, the reason they're going to lose Medicaid is because they're now working and they may have access to insurance through their employer. We want to make sure they're aware of what they have access to. And if we get the less than a dozen states who are still not offering expanded Medicaid to their populations, which was made available through the Affordable Care Act. Thank you, Governor Cooper in North Carolina, for moving forward. I hope they're successful. Then that would be another way to make sure you cover another large segment of those 16 or so million who might lose their coverage. There's no reason why we can't find a way to cover Americans. We saw what happens when you have access to care. And at the end of the day, I think it will be beneficial for all of us. So we're working hard to make sure governors know what's available to them, and we'll do everything we can under the President's leadership to make sure everyone stays covered.
Last one. You've been in this role for almost 2 years now, almost exactly. A lot of people look to the door after 2 years. It's a tough job. So,
You know something I don't know?
No, but I am going to ask you, what else do you want to accomplish before you say, I've done my job here?
Oh, gosh. Preparedness, they're just around the corner, guys. We almost had Ebola coming over here. But fortunately, the Ugandan government and its leadership and its people did everything to contain what was a growing infection of Ebola, which, by the way, we don't know what we do with Ebola if it hits. But we were, and by the way, our CDC, our folks were working really hard with the Ugandan government on that. So preparedness is still big, and it's a shame, but I think there's a sense in quarters of the country, including down the street on the Hill, that we're done. We made it. We're clear. We're not. Mpox, that wasn't fun. Monkeypox. Ebola would be fun. Avian flu comes, you're in trouble. We're in trouble. So there's preparedness. So we still have a lot of work there to do. Obviously, making sure, as I said before, everyone has access to the health care they need. I don't expect that these rulings will stand on abortion care for long, but it really will. It probably be more about the American people making it clear that this can't stand for very long. It won't be because there will be some sense of sanity in the courts to get us there. But I don't think it'll be there forever. Meanwhile, we're going to have to do what we can to make sure that we don't let anyone lose that access to the care that they need. And so, none of the things I mentioned to you, the Affordable Care Act, we're now at 16.3 million people. When the president came in, there were 11.4 million people who were getting their health care through the marketplace. During the height of President Obama's term, they got to, I think it was 14 or so million people. We are way beyond where they were before. So we're like Captain Kirk. We are going places where no one's gone before. And so we still have places to go. I think you're gonna watch with interest as we start the negotiation for drugs and the price on those drugs. Stay tuned, that one's going to be fun. I think later this month we're going to show you a roadmap and how we're going to do it. I need more than 2 years. So there's still a lot.
And that wasn't a suggestion, by the way, but the choice word of fun for drug price negotiation. Anyway, thank you, Secretary, for being here, and thank you all.
Thank you all very much.
Yes, thank you so much, Secretary Becerra, and thank you, Sarah. With that comes the close of our program. But for those of you in this room who are not already taking full advantage of all the ways STAT can support you, right outside this room in the reception area, you'll find some folks from our team who would love to show you more about all of our stat solutions, including how your entire organization will benefit from a Stat Plus subscription, or full access to the Stat Reports Library, or our latest clinical trials intelligence platform, Stats Trials Pulse. We offer tons of bundled solutions and discounts, so be sure to meet with the team and schedule some demos for later this week or next week. I just want to say thanks again to all of you for joining us. We definitely learned a whole lot today. We had a jam-packed agenda, and our moderators were fantastic. And you were all fantastic as well. You had some great questions, a lot of energy. You bared with us while it's a little toasty in here, but thank you all so much. And now I want to give a special thank you to our moderators, Rachel Kors, Nick Florco, and Sarah Overmall, to all of our panelists for sharing their stories and their expertise, and to our event sponsor, Alexion AstraZeneca Rare Disease, for making it all possible. And a special thank you to my event squad, Julia Baker, Caitlin Clark, Britt Cipriano, Shannon O'Callaghan, the newest member, Catherine McPhail, and Matt Herper. There's more food, there's drinks outside as well. You can stay for the next hour or so. So enjoy, and thank you again so much for coming to our STAT event here in DC. Take care. Good night.